Good evening, sir. My question is 3 years old, presented in the AR with a stridor and drooling of saliva and restless. He was found to be playing with a toy operated by button cells, suspected to have swallowed it. So this is seems to be a foreign body ingestion, which is an acute, sensitive, and emergency scenario because these batteries they generate a chemical reaction and creating a potential difference and drives the charged particles to flow through the medium. This can conduct electric current and cause injuries to the surrounding mucosa. Mostly, it is due to the hydroxide ions released at the anode level in the battery, which causes the caustic injury around the mucosal level. Usually, the acid usually causes a coagulative necrosis, where the alkali usually causes a liquefactive necrosis, which is uh, uh, very dangerous presentation. Uh, the risk associated usually depends on the location, duration of presentation, the size of the foreign body ingested, and the age of the patient. The location, most commonly, it will be around the C5 level, which is the upper esophageal sling, yes, like what the scenario has been given. It might also be at the level of T5, the mid esophageal level, compressing the aortic arch. It might be in the T10 level, G gastroesophageal junction, or sometimes in the pylorus T12 or DJ flexure levels. Beyond that, it might pass away. Complications, it usually based on the site of presentation. Most commonly, GIT, it can lead to a perforation, stricture, fistula, mediastinitis, vertebral osteomyelitis, etc. In the respiratory system, it is very crucial. It can lead to airway obstruction, which can be a complete or partial one. In case of complete airway obstruction, we can expect a bradycardial arrest in the children. This scenario seems to be a partial airway obstruction. It can also later lead to a tracheal stenosis, hemorrhage or tracheoesophageal fistula, and aspiration pneumonitis. If in case presented inside the nose, in the upper airway, it can lead to a perforation. In long term, it can lead to perforation, synechiae, or a periorbital cellulitis presentation. In the ear, it can lead to a tympanic membrane perforation and seventh cranial node paralysis. So coming to our scenario, we need to do a detailed, we need to do a quick history. Like in case of, we need to ask about the allergy, last meal, any drug history, what the baby is on, and about the past medical history, and what was the exact event leading to the presentation of this current scenario. And quick general examination should be done. Attention should be given to the airway, respiratory tract and CVS, and GIT. If delayed presentation, we need to look for the sepsis, pneumonia, and gastro GIT signs. Then principles of management, ideally ABC approach, which is airway, breathing, and circulation. We need to order a quick imaging of the neck, chest, and abdomen. In this case, I would like to have a X-ray neck and X-ray chest very quickly. And we also need to send for the labs if we suspect sepsis. We can divide the scenario into a stable or unstable scenario, or it can be emergent or urgent scenario. Here it seems to be like a partial airway obstruction. I would like to give an adrenaline nip and IV corticosteroids and to reduce this airway edema. Careful preparation of the difficult airway, the difficult airway cart and everything should be essential. Quick communication inside the OT and experienced ENT surgeon should be called for. Two, anesthetist presence inside the OT is required because it's a shared airway. We need to define roles and we should carry out a proper plan. Um, we can prefer a spontaneous ventilation over elective ventilation. Uh, in case of severe burns, like the baby has presented like after 12 hours presentation, in that scenario, early elective tracheostomy can also be suggested. Intra-op, we can prefer antiemetics. We can go for a sevoflurane induction. In case if baby has an IV line, we can go for a IV induction. Then we need to give a glycopyrrolate 10 mics per kg. Steroids we are given in the pre-op. I'd like to give a ketamine 2 milligram per kg sedative sedation dose, and with a fentanyl 1 to 2 mics per kg, and a propofol 1 milligram per kg IV infusion. I'd like to have the spontaneous ventilation uh, as possible. 100% O2 can be maintained. Since it's a shared airway, I would like to ventilate with a rigid bronchoscope side port. That's also a few red flags for this batteries. The battery size is more than 20 mm. Age of the child is less than 4. If the battery is made up of lithium, and if the presentation of the battery is in the esophagus, and the presentation of baby after 2 hours, this can have a impact on the baby. That's also. So the algorithm, like complete and partial airway obstruction. So in case of complete obstruction, we need to check for the responsiveness of the baby. If no responsiveness, we need to start the CPR, and we have to follow the ACLS guidelines. If the baby is responsive, we can go for a back blows and chest thrust. In case of adults, we can go for abdominal thrust like Hemlich maneuvers. If it is suspected to be a partial airway obstruction, as in our scenario, in case of upper airway, we can go for X-ray chest, neck, and neck AP and AP, I mean PA view and the lateral view. If the foreign body is detected, we can go for either a direct laryngoscopy or a nasal endoscopy, and we can take it away. Or we, if it is not detected, also we can encourage some cough. If the presentation is in the lower airway, with the presentation of cough, wheeze, and reduced breath sounds in the chest, we need to order for a chest X-ray and chest X-ray and chest X-ray abdomen. Then, if it is also not detected, we can go for a CT chest or bronchoscopy, and planned removal can be done. That's also.
Okay. So here, why do you suspect it could have gone into the GI? The clinical scenario that is given says the patient is having a stridor, is drooling, is restless, is tachypneic. So all these things indicate that the foreign body has entered the respiratory tract rather than the GI tract. Okay. So that is the more important thing that you have to remember, not to waste time on describing about where the GI tract aspiration could have happened. Okay. And once you know it is in the respiratory tract causing the stridor and difficulty in breathing, it is a foreign body which is in the upper airway. Because once if it has gone too down via the trachea into the major bronchi and into one of the divisions of the major bronchi, patient will not be clinically so distressed. Okay, they may have a persistent cough. More than that, it may not show anything else. So that is a less emergent situation. And the foreign body, whether it is organic or a non-organic foreign body, if it has gone down below the tracheal level into the bronchi, then it produces a less emergent situation of airway obstruction. On the contrary, when the foreign body is lodged in the trachea or just a subglottic level, that is the more dangerous situation where it has to be retrieved as early as possible to prevent further complications. Okay. So here it is obvious that it is only in the tracheal level, not in the bronchial level, because of the clinical picture that is being given. And the best way to remove is using a rigid laryngoscopy and pulling it out with the forceps that is available. Why rigid laryngoscope is the ideal instrument for removing such foreign bodies, not the fiber optic bronchoscope that we normally use? What are the advantages of rigid bronchoscope?
One thing, we can ventilate with a side port and rigid bronchoscope, sir.
Okay.
Then the other thing, the instruments are easy to pass in the rigid bronchoscope, like the stellate.
So these are the two important reasons why normally they do only a rigid bronchoscope or laryngoscope for retrieval of such foreign bodies that have been aspirated. And before you maintain, you said about you will use ketamine, you will use fentanyl, you will use propofol, and What is the inhalation agent you will like to use?
The sevoflurane injection, sir.
Sevoflurane in?
Like oxygen and air combinations. I prefer, sir.
100% oxygen. It is
100%
always
oxygen.
100% oxygen and sevoflurane, not air or nitrous oxide in these cases. But any other better technique than inhalation agents? What is the other method of maintaining unconsciousness
IV
without
injection. Intravenous injection. Intravenous
total
injection.
intravenous anesthesia, TIVA, okay?
Yes.
And before doing any intervention, what is the best method to achieve or subdue the airway reaction? Before introducing the bronchoscope or the laryngoscope,
Pre-oxygenate.
pre-oxygenation.
Denitrogenation.
No, when the instrument is going to touch the larynx, what can happen?
We can spray local anesthetic spray.
In areas with local anesthetic is an important step. Okay.
Yes.
So that is also have to be mentioned in this case. So I'll just share the thing how to do that. Is it visible?
Yes, sir. Visible, sir.
So, sorry. Namachi has to start recording only after we see the slide correctly. Otherwise, all these things get.
Sir, I was also thinking that way, sir, but I thought it will be a rapid recap and OSCE preparation as you move the slides fast. So
Okay.
in one recording slot, they will be able to go through all the other things, sir. Yes, sir. Sorry.
3 years old toddler brought to AE with stridor, drooling of saliva, restless eye, playing with a toy. So what are the challenges in this case? Common surgical emergency in children and challenges of pediatric anesthesia. Because 3-year-old, with separation anxiety and all the anatomical and physiological differences of pediatric anesthesia are there. And problems include maintenance of patent airway and avoidance of airway obstruction, high risk of hypoxemia during shared airway, and the prevention and management of possible postoperative airway problems. So these are all the challenges that can be faced in this case. What are the points in preoperative assessment? The anxiety of the child is to be minimized by developing a rapport with the patient or parental presence at induction, and pre-medication with midazolam or clonidine if needed. And use the ample history for the allergy medication, past medical anesthesia history, last meal events leading to the presentation, and ask about family history of problems with anesthesia like sudden death or malignant hypothermia. All these things have to be quickly asked in the pre-anesthetic assessment time. And examine the child with the focus on the airway. Look at the neck and chest radiographs for the position of any radiopaque foreign body. So if it is a coin, it will look like a homogeneous circle. Whereas if it is a button battery, you may get what is called the double ring or a halo sign. You can see a small another ring inside, the outside darker ring. And so how to differentiate a coin from the battery in play. Now how to manage preserve spontaneous breathing, especially when it is a upper airway foreign body. The most important answer the examiners expect from you is to preserve the spontaneous breathing. Whereas if it is migrated down to the division of trachea into bronchi and distal part of the airway, then you can definitely control ventilation. Whereas here, by paralyzing the child and controlling the ventilation, you will be pushing the foreign body into a critical situation where you cannot ventilate. So that is the reason why you have to maintain the spontaneous breathing so that some amount of uh, oxygenation can go on. And induction of anesthesia can be inhalation or intravenous. The safe approach is to use anesthesia with sevoflurane and oxygen. And an alternative IV induction is fentanyl 0.5 microgram followed by incremental doses of propofol. And then you can increase the dose until the child loses consciousness. But do not give these drugs in a rapid fashion or a higher dosage because the child may stop breathing at the time. So another option is to use dexmedetomidine also, 1 microgram per kg. This is a newer drug that we all use even in children. And maintenance can be done by volatile agents insufflated through the ventilating bronchoscope, or use of TIVA avoids the need to use the airway to administer anesthesia when the airway is shared. And there is less pollution and exposure of the team members to waste anesthetic gases. This is the advantage of TIVA. And during initial maintenance phase by inhalation or IV, deepen the plane of anesthesia until the patient is deep enough to tolerate the application of topical local anesthetic airway. So the airway is a very, very important step in the management. So before you introduce the ventilating bronchoscope, you must apply 4% or 2% xylocaine to the airway and wait for a few minutes and proceed slowly, because if anesthesia is too deep, the patient will stop breathing. And if before the topical takes effect, if you proceed and do something, it may stimulate a spasm. So start with a propofol 250 microgram per kg per minute. And nowadays, because remifentanil is also available, which is a short-acting drug, we can use it at 0.2 microgram per kg per minute. So this combination as a total intravenous anesthesia is an ideal one for this procedure, where we need not rely on the delivery of inhalation agents, which is to be mostly intermittent. And titrate propofol to the respiratory pattern, muscle tone, and heart rate. Supraglottic airway device can be inserted to maintain the airway in some cases where you have the special bronchoscopes available. And for local anesthesia of the airway, perform a direct laryngoscopy before the surgeon introduces the bronchoscope, and spray with lidocaine 4 milligram per kg dosage at the both on the vocal cords and through the vocal cords subglottically also, with an atomization device or a small gauge IV cannula can be fitted to the syringe and you can spray that. And if the child coughs, oxygenate the patient's lungs with face mask until spontaneous ventilation resumes. Continue to topicalize the airway. It is essential to maintain a deep plane of anesthesia during the procedure, as coughing and bucking on the rigid bronchoscope may cause trauma and bronchial or tracheal perforation. And removal of foreign body through the larynx is the high risk time. Sometimes, when they try to hold the battery and try to remove it, and if unfortunately it gets slipped, then it may get stuck between the vocal cords. And it may completely choke the patient, and it will be very difficult to ventilate. So that is the most risky time. A bolus of propofol to ensure adequate depth of anesthesia can be given at the time, despite the fact that you are giving a continuous infusion in the form of a TIVA. Maintaining oxygenation throughout is a challenge. If surgeon has passed a ventilating bronchoscope through the vocal cord, attach a breathing circuit with a 22M connector on the bronchoscope. So this is the bronchoscope, and you can attach your regular breathing circuit and ventilate through that, or you can attach a oxygen source tube like this. And if the surgeon is working at the level of the larynx, so this will be a bronchoscope which will go into the trachea, into the up to the carinal level. Whereas this is a laryngoscope. This is not a bronchoscope. So this is remove the things which are more superficial or more in the upper airway. So if this instrument is being used, which is a laryngeal level, then you can insufflate oxygen through the tracheal tube, pass through the nares into the nasopharynx also. So the options when this instrument used are, one, you can attach oxygen to the side port of this laryngoscope, rigid laryngoscope, or you can, because the larynx is open now, you can insufflate oxygen through a tracheal tube that has been passed through the nostrils up to the nasopharynx, just above the vocal cords, and continue the inhalation. And because patient is breathing spontaneously, they will receive adequate oxygen. And transnasal humidified rapid insufflation ventilatory exchange also will be used to maintain oxygenation in this situation. And communication with ENT or endoscopy team is essential throughout the case to prevent the hypoxia. So these are the points that have to be remembered for this particular case scenario. Okay. So you need not waste time on telling about the aspiration into the gastrointestinal tract and all the reaction and all those things. This question is mainly to judge your ability to manage a foreign body in the respiratory tract because of the clinical scenario and the clinical symptoms that have been described. Okay.
Yes, sir. Carried on was there was like drooling of saliva history and restless, sir.
Drooling will happen because the patient who are struggling to breathe will always have excessive stimulation of oral and pharyngeal secretions because of the foreign body in the respiratory tract. Okay, that is why
Yes,
the
sir.
drooling occurs.
Okay, sir. Thank you, sir.
Shall we go for